We don't have an issue,
We
but
don't
then
have-
we are worried whether the patient will take it well if he comes after 1 year. Whether the adaptability will be okay.
1 year,
That's
because there are many a time one eye is operated in one hospital maybe 2 years back, and then they come to us and we operate it. Nothing. I think they are happy. But only thing is, if they are not coming, also it's their problem, and they must be happy with that one eye. Very happy.
Fine. Thank you.
So that brings the end of the session. I thank all the speakers and the audience for the patient hearing. Thank you.
Thank you. Who's on first? Okay, you go. You go tell them you're Kiran. You go tell them you're Kiran. Good afternoon, everybody. We'll go into a session on dilemmas in glaucoma. There are always two ways of dealing with the same problem. And we start off with Dr. Kiran, is a consultant in Precise Eye Hospital, Trivandrum. And he will be telling us about whether to do a phaco or a phacotrabeculectomy when you are confronted with glaucoma with cataract.
So, both cataract and glaucoma in a given patient, a very common clinical scenario that we face. So, we know that for cataract, you basically treat it by simply doing a phaco, right? And for glaucoma, we know that the best procedure to get a very low target pressure is trabeculectomy. But can phaco also help you in glaucoma in some extent? That's the basic question. If phaco trap was such a simple procedure and it was as predictable as phaco, obviously there is no confusion. We would do phaco trap in every patient to get low pressures. But the problem is when you add trap onto phaco, you also invite a lot of complications. Generally, phaco trap eyes tend to have slow visual recovery. They also invite a lot of the trap complications like hypotony related complications. And if you don't have complications, you are more likely to encounter multiple small procedures in the post-op phase. You might have to do needling, you might have to do suture lysis, and none of these are a part of phaco. So when you add trap to phaco, you lack the patients will lack the wow factor that phaco brings in compared to phaco trap. So we'll start the discussion on what is the effect of cataract extraction on the angle of the eye. So this is an anterior image. You can see pre-op angle closure glaucoma and see what happens when you perform phaco. You see a slow transition there. That's what has happened. The thick lens has been replaced by an IOL. The iris has fallen back. The the AC angle has widened, and the anterior chamber depth has also increased. Of course, you can make it out with. If you look at the pre-op parameters, you see the aqueous depth is 2.19 and the AOD, TISA, all these are markers of the angle, and all these actually increases to quite a significant extent in the post-op phase. So this is an example of an angle closure glaucoma, but we know from literature that this change in angle parameters favorably happens not only in angle closure glaucoma eyes but also in open angle glaucoma and control eyes. So even in open angle glaucoma or control eyes, you can see that from a pre-op anterior chamber angle width, there is an increase in open angle eyes as well. But the angle widening is maximum in the angle closure group, but you do have a change even in the other two groups. But what happens to the angle when you add trap to phaco, when you do a phaco trap? So this paper looked at that. So they looked at two things. One is what happens to the degree of synechial angle closure, right? So the synechial angle closure decreases after phaco and after phaco trap, but to a greater extent in phaco alone group. So even if you have synechial closure, a part of the synechial closure does open up when you perform phaco. And if you look at the UBM parameters again, you find that all the parameters improves favorably in both the phaco and the phaco trap group, but the angle widens to a lesser extent in the phaco trap group, which is not surprising because you have a filtration that is happening in the anterior chamber in the phaco trap group that offsets some of the positive effects of phaco. So what happens? These are the changes in the angle. But what happens to intraocular pressure when you perform phaco in glaucoma? So there are a lot of studies which have looked at a lot of these things. So the American Academy came out with this ophthalmic technology assessment in 2015. So they looked at a lot of studies that looked at the effect of cataract extraction on POAG patients. These are the number of studies, except one study with level 1 evidence, all the others are 2 and 3. Similarly, a lot of studies with PXF, a lot of studies with PACG as well. And these were the results. So you can see that there is an effect of intraocular pressure reduction if you perform phaco, but this effect is very mild in primary open angle glaucomas, tends to be moderate in pseudoexfoliations, and tends to be quite significant in chronic angle closure glaucomas. And even if you look at the number of medications pre-op and post-op, you can find that the same results are replicated with maximum reduction of medications with the chronic angle closure glaucoma group. Now, the most dramatic result is obviously obtained in acute primary angle closure glaucoma. When you have an acute angle closure crisis, and you can find that when you perform phaco alone, there is almost a 70% reduction of intraocular pressure from a mean value of about 50 to almost 15. And we try to look at what are the different predictors of IOP reduction. So from the current data itself, we know that the angle closure glaucomas tend to have a good impact when you perform phaco. But within a glaucoma group, what are the predictors of intraocular pressure reduction? So the only factor that was found consistent was a high pre-op intraocular pressure. You had a higher pre-op pressure. If you perform phaco, you got a larger magnitude of reduction. But all the other biometric parameters, the AC depth, the angle width, the synechial closure, lens thickness, axial length, all these parameters, lens thickness, lens fault, they were found to be inconsistent predictors. So some studies found some correlation between, say, a low pre-op AC depth to associated with a good IOP reduction, but not in all studies. So these were inconsistent predictors. And the complications of phaco alone in a glaucoma patient versus a non-glaucoma patient. And they primarily looked at two things. One is IOP spikes and other phaco related complications. So IOP spikes were higher than average when you are operating phaco on a glaucoma patient. It's on an average around 20% in most cases in the early phase. It's higher than average. But with improvements in modern phaco technology, the phaco related complications were very similar. So if you are performing phaco on a glaucoma patient, even in chronic angle closure glaucoma patient, the complication rates were not very dissimilar from performing it on a non-glaucoma patient, with one honorable exception, that is acute primary angle closure glaucoma, obviously, where there was a very high incidence of corneal edema, fibrinous reaction, and wound leaks, which is not surprising. You are operating in a practically non-existent space. So, if you have cataract and primary open angle glaucoma, it is the degree of pre-op control of glaucoma that is the deciding factor. So if you have a medically controlled POAG, you can generally get away with phaco alone. If you have a medically uncontrolled POAG, since the effect of phaco on POAG in terms of IOP reduction is very low, you will have to add on an IOP lowering procedure. And of course, if the current pressure and the target pressure, the delta is very high, you will have to use a trab, or you might consider angle procedures if the delta is actually low. But generally, you will have to add on an IOP lowering procedure if you are dealing with a medically uncontrolled POAG. Of course, if you have cataract in acute primary angle closure glaucoma, after you perform the basic medical control and the PI, and if it's still not getting controlled, you can do a trial of phaco alone. Very difficult surgery. You should be prepared for complications, but it's certainly going to be more easier than performing a phaco trab. But the question is, can I get away with phaco alone in chronic PSEG? So, study published from India, 2021, Dr. Shirisha from LVP. This is a cohort of medically controlled primary angle closure glaucoma patients, right? And they found that after about 6 years, if you are medically controlled PSEG, the Kaplan-Meier survival probabilities shown between the two groups are very similar. So they have similar results in terms of the survival of the eyes. But as expected, higher complications in the phaco trap group. Interestingly, they found higher IOP spikes also in the early postoperative phase of the phaco trap group, and one case of malignant glaucoma as well, and much slower visual recovery, which took almost a month in the phaco trap group compared to the 1 month in phaco group, and obviously procedures like needling, etc., which needed to be done in the phaco trap group. So in medically controlled PSEG, yes, you can go and do a phaco alone. What about medically uncontrolled PSEG? So this is exactly what Dr. Tam looked at in this study, which looked at only the cohort of patients with medically uncontrolled PSEG. Again, medically uncontrolled here simply refers to pressures greater than 21. So you can see that the phaco trap group had lower pressures at all time points. But even the phaco alone group had a significant reduction of intraocular pressure in all time points. But the biggest difference happens not in terms of the mean IOP, in terms of the number of post-op medications. In the phaco trap group, practically with no medications, you could get low target pressures. But in the phaco alone group, you will require some degree of medications to keep the pressures under control. But again, when the phaco alone group had no reported complications, because they reported PCO as a complication, I'm not even including that here. But phaco plus trap group included about complications that included minor things like needling and major things like wipeout in 2 patients and revision in 1. So, considering all this, and also another fact was that those patients, about 15% of patients actually subsequently required trabeculectomy after performing phaco alone. So in the cohort of medically controlled, this was only about 3%. So actually, if you look at it, in medically uncontrolled PSEG also, in general, you can try a trial of phaco alone, but you have to be aware of the fact that some of these patients are likely to require trabeculectomy later. And also, if you just looked at the previous study I mentioned of medically uncontrolled glaucoma, the mean pre-op pressures were about 25, 27. But we might end up having patients with 30 or 40 pressures and very advanced cupping. In such cases, you have to individualize and decide for a phaco trap. Thank you for your kind attention. Dr. Thomas will speak to us on primary angle closure suspects. So, should you do a laser peripheral iridotomy or not?
Thank you, Kiran. In angle closure, we have what we think is a primary mechanism as a relative pupillary block. Iridectomy or iridotomy would take care of the pupillary block, so laser PI being easier would be the way to go. But do we need it? Does it work? Especially at the PSCS stage where the patient actually doesn't have a problem yet. PSCG, there's no problem, we need to treat the fellow, and closure primarily needs surgical treatment, so PI would be the way to go. The data we have always had is the Valorai survey, 22% of the PSCS suspects progress to primary angle closure, not yet glaucoma, in 5 years, and 11% of the PSC angle closure with Sineke who underwent PI still progressed to PACG in 5 years, and 36% of those who refused PI progressed to angle closure. So what it shows is PI doesn't deal with the closure element fully, and those who have PI